Hello, good evening. Welcome to our NYU Orthopedic continuing series webinar. This is a new entry into the orthopedic series this year. Myself and two of my colleagues who are interested in bone and soft tissue tumors are going to try to give just a very general overview of, we're calling it bone and soft tissue tumors, musculoskeletal oncology. It's an area that, although the problems sometimes seem a little bit obscure, stuff that certainly you don't want to miss. And again, the audience, I think, is intentionally broad. So I'm going to speak as if we're speaking to, not only primary care, but some pediatricians, orthopedic surgeons, maybe even some medical oncologists that are see metastatic disease or other issues that pop up. So we purposely have made this kind of a broad topic. So we encourage you to use the chat or to answer or to ask any questions. Please feel free to do that. We're going to try to keep it as informal as possible as you can on a streaming webcast. So my name is Tim Rapp. I'm an associate professor here at NYU, and my two colleagues and I have all completed fellowships in orthopedic oncology, and my two colleagues actually have done dual fellowships, not only in musculoskeletal oncology, but also in pediatric orthopedics, as there are a number of issues pertaining to bone, soft tissue tumors that are encountered in the pediatric age group, and so that gives them some special expertise which we're happy to have tonight, and that's Dr. Karim Masrouha and Dr. Henock Wolde, who will both be speaking. So at this point, without further ado or introduction, I'd like to introduce Dr. Henock Wolde, who's one of our orthopedic oncologists, works primarily out at NYU Long Island. But he's a valued member. Again, he's done two fellowships, not only in oncology, but also pediatrics. And he's going to give an overview of the general workup of bone and soft tissue tumors. So Henock, take it away.
Thank you, Tim. Like my colleagues, I'm delighted to see so much interest in orthopedic oncology. It really is a very rewarding field, and I appreciate working in the field. And I am primarily based out of the Long Island Hospital. And so today I am going to start the talk with a general overview, bone and soft tissue tumors in general. And I hope in this talk that I'll be able to give you some idea of not only their origins, but the workup and some of the information out there, prevalence, types of imaging, and the workup leading to the diagnosis. Okay. So we'll jump right in. So when we first talk about just bone and soft tissue tumors in general, there's many ways to classify, but one of the more easy and more sort of straightforward ways of looking things that present is whether this is a primary or a secondary tumor. Is this something that a lesion that is in the bone and soft tissue tumors and grew out of that tissue, or is this something that has spread? So most growths of the bone and soft tissue tumors are mesenchymal derived. That means that came from the mesoderm. And I don't want any flashbacks of miserable experience in embryology, but just a quick breakdown, because I think it is sort of important to know that early on, very shortly after the fertilization of the egg, there are three germ cells that arise, and the mesoderm is one of these. And just about everything we do is within the mesoderm. And it is different in the sense that a lot of the more common tumors arise out of the endoderm and the ectoderm. And so that's why sarcoma has a bit of a different approach to it. Sarcomas, which are malignant tumors of the bone and soft tissue. Now, not everything of the bone and soft tissue is a malignant. Many benign lesions that occur. So in looking at this, the mesoderm spawns the mesenchyme. And the mesenchyme, which is part of these stem cells, these cells that develop out of the original cells that develop, goes on to develop into many types of tissue, as you can see from this illustration. it spawns sort of the skin, the cartilage, the bone, the adipose, which is the fat cells, and the muscles and the nerve cells, and various other structures. But in orthopedic oncology or musculoskeletal tumors and so forth, we primarily deal with these types of tissues, okay? Now, and that's, again, alluding back to the fact that these are things that originate out of the bone and soft tissue tumors. So, these are lumps of bumps and masses and lesions that vary in their appearance, in their presentation. They could be large, they could be moderate, small, as you see in these images. They could be in the arm or the thigh or the knee. And so, when these present, they're a dilemma for all of us. When they present to our patient, when the patient presents to our clinic, they're usually complaining of some kind of lump, and they're not really usually sure when it developed or how it developed. All they can tell you is that it might be growing or it's painful. And so, for us, it really is about sort of the odds, the presentations, the prevalence. And we see a great majority, as you can see, particularly like this is a breakdown in bone lesions, but you can see like a majority of lesions are just benign, and I'll get into what the workup will entail. But just so that when we're looking at lesions, whether it's in the bone or just masses that present to us, a great majority of them are benign, and very, very small percentage are actually malignant tumors. And then, as you can see, the percentage of metastasis when they present to us. And, I wouldn't let this terrify you, but this is just a small example of what the great number of benign lesions there are of bone in general. So, it is sort of in our workup that we come across and do the differentials and sort of figure out what exactly we're dealing with here. Is this a benign tumor? Is this really even a tumor? Is this more of a dysplasia, a malformation of bone of some type, or is this something that will continuously grow like a tumor would? Okay, and then, of course, the question is, well, is this something that I have to worry about that will impact my patient to a large degree, like life and death? Is this a sarcoma? And, very much like the breakdown I showed you earlier in terms of the embryology, the origins, there are malignant tumors of just about every type of tissue out there. Fat cells can transform into liposarcomas, fibrous tissue in general, or any connective tissue can transform into fibrosarcomas. And you might have heard of osteosarcomas and Ewing sarcomas, which are some of the more, well-known tumors that can affect the bone and soft tissue, and chondrosarcomas of the cartilage. So in sarcomas in general, the origin of the name itself is Greek, just meaning fleshy, but these are high-grade tumors. And there are some moderate ones, but for the most part, the ones that we worry about are high-grade, and they metastasize, and they have very aggressive local effect, and the question is mortality. How much, what can be done about this? Or what is it that exactly we've diagnosed here, and how do we treat it? So is there sort of a standard of care for this? And so that pretty much encompasses all of the primary bone and soft tissue tumors, benign or malignant, and then later on you'll hear a talk from Dr. Rapp regarding the metastatic tumors, which are the secondary tumors, and what those tumors are like, how do they present, and sort of what are the challenges in treating them, okay? So the workup, what exactly are we talking about? Generally referencing workup, we're talking about the physical exam, imaging studies, in our case, the biopsy and the staging. So, yes, we still do physical exams in orthopedic oncology. A lot of people think we just sort of send them right off to MRIs, but it is important. It's whether the mass is deep or subcutaneous, or, is this something that's mobile? Is this affecting lymph nodes? So a good physical exam goes a long way, even to just communicate with the patient themselves. They might not even really know what exactly is involved here. They may not have a deep appreciation of the full extent that it's affecting their neurovascular structures. So, lay a hand on the patient, do an examination. It even pays to do a little measurement sometimes. You never know. There may be some growth in the mass. And, if this is something that was observed before by another doc, and you have some frame of reference to measure, you can see if something is growing or is stable. And so when the patients present to our offices with these various types of lesions, the physical exam is a big part of our exam. Now, contrary to popular opinion, we don't dissect and take out tumors right there in the office. At least I don't. My colleagues, I think, can jump in and say, having someone like Dr. Pimple Popper on the TLC, who you could just show up to the office and, she'll just tell you, oh, I think it's a fatty mass, cut you open right there, and I'll take it out in the office. Is not really a practical thing. Great for ratings, but not really the most recommended thing, I would say that probably the first thing you should think about is, have I seen enough? Has there been an adequate imaging of this thing for me to have some kind of clue? So, as I, give you advice about the kind of presentations that might come to your office, and as you sort of work through your, algorithm of how you work up your patients, X-rays, MRIs, bone scans, CT scans, these are all sort of what we use to sort of work up our patients. And I'll jump right in there. X-rays still are relevant. They may not by themselves sort of give you everything you need, but if it's a firm mass that's bony and doesn't move and has been there for most of the life of the patient, it's possible you may not need any further imaging. So I think X-rays are a good first study to do in the office. Very easy access. Most of us have X-rays in our offices, and it could be helpful. For instance, in this X-ray here on the left, we see a bony outgrowth, an exostosis, and my colleague will talk to you about how these present in the workup. But when I see something like this, it's immediately comforting. I can share with the patient, and I may not even have to do any further workup. So yes, I still use X-rays, and Dr. Rapp and Dr. Masrouha will chime in and let me know how much they use X-rays really. But to be practical also, insurance companies don't want to pay for MRIs if you don't get X-rays at first. So even if it's not that useful to you, you find that you sometimes have to order just to document that you've looked at an X-ray and that you're still curious about how aggressive this mass may be. And so, and then I'll give you a clinical correlate. It's not exactly just, hey, I looked at it and I'm still going to order an MRI. There's a lot you can get out of things, one of the things you could come across is that, if you've got the right history, say, for instance, you have a teenager who's very athletic and, recalls playing soccer and getting lots of kicks to the thigh, over time, they may present with something firm and pain, and X-rays would be the first thing you get. And being familiar with sort of the type of ways that myositis ossificans presents can get you out of a lot of concern and anxiety, and stop you from alarming everybody without proper due. So this is sort of how myositis ossificans can present, and maybe one of the differentials in the presentation. Another common finding in the X-rays is just calcifications within a soft tissue tumor themselves. Often referred to as phlebolytes, but there are at least 2 or 3 soft tissue tumors out there that are known to have some internal calcifications. Hemangiomas in particular tend to be very benign, and you probably wouldn't stop with just getting an X-ray. But part of the thing with us, is the challenge is that we've learned as professionals, as we develop, to have some working diagnosis to try not to be just shooting in the dark sometimes. And so if I saw some calcifications on the X-ray, I might be inclined to narrow down my differential diagnosis, and then I would move forward with the next most adequate or proper or more appropriate imaging. And here's sort of another example of a typical benign presentation of a patient who had a firm mass in the posterior knee, and then you get an MRI. You can sort of get further detail from that, and that leads me into sort of the next part of the workup, which is in terms of imaging, which is the MRI with and without contrast. It's sort of our gold standard in working up our patients. It's extremely useful in defining all the involved vital structures. And it's important to obtain these images before the biopsy or anything further is done. I alluded to Dr. Pimple Popper sort of excising lesions in the office and then sort of coming to a conclusion. Well, I would argue, in most occasions, and at least the way I was taught by my mentors and how we practice, we like to know what we're doing, what we're cutting out before we suggest even cutting out. So it's a very low risk, and especially with the contrast that's involved with MRI being gadolinium, it sort of gives us an advantage. It enhances the mass based on the vascularity, and there's so many sequences of an MRI, so helpful. You're looking through every sequence to try to figure out what is the nature of the tissue. Is this a fatty tissue? Is it more fibrous tissue? Does it have the sequence of, is it as bright as muscle or, fat or, and then when you look at the sort of the contrast, in this case here, the image on the right is, a fat suppressed contrast enhanced lesion, and it showing you that this is a mass that doesn't have much fat and it's enhancing with contrast, which gives us a lot of information. If it was all dark under fat suppression, we would say to ourselves, this is most likely to be a fatty mass, a benign mass, and, with this one in particular, it being an outside image, it came with a CT angio, which we don't necessarily usually use, but you can see how the contrast in this of the MRI was able to show you that this mass was enhancing. So, it's very, it's relevant, it's useful, clearly delineates neurovascular bundles and what's involved. And so, I find in practice, a lot of people get an MRI without contrast. And I often ask myself, well, someone, referred this patient to me, had the foresight to realize that there's a mass here and that probably an MRI is necessary, but they sort of hold back on the gadolinium all the time. And I kind of want to put this slide here to sort of reassure you that, first of all, it makes a big difference. It isn't always necessary, but it helps us sort of delineate things. And there are very few contraindications: pregnancy, previous allergic reaction, and severe chronic, kidney disease. But otherwise, we're talking about a contrast that is processed much safely and, metabolized and excreted much easier than CT contrast, and with very minimal side effects, probably for our younger population, we probably worry more about the pain and discomfort of putting in an IV and than the effects of gadolinium in general. So severe allergic reactions to gadolinium are very rare. They're not like CT contrast. So I would implore you, if you're thinking about a mass out there that you're working up, it's worth it for you to have a 2-minute discussion with the patient. Let them know gadolinium is usually safe and that it's something that would add a lot of useful information in the assessment. I mentioned earlier the MRI. It's critical that it's obtained prior to the biopsy, as you can imagine. Putting in a needle through the soft tissue, and then causing trauma to the tumor, and then coming back out can have, effects and consequences that will then, if you were to get the MRI after the biopsy, you don't know what came first. You don't know if you have a hematoma because you caused an injury through the biopsy. You don't know if there was contamination. So get the MRI before you suggest the biopsy. It's always a good way. It's not just academic, it's safer for the patient, and it'll also give us more room to discuss a proper and safe option for the biopsy, sort of the approach to the biopsy, which I'll talk about in the upcoming slides. There is still a role for ultrasounds, although it's not very helpful in the sense of getting good definition. It is inexpensive. We work with young kids sometimes, and sometimes, in our institutions below 5, you need to be sedated to get an MRI. And so an ultrasound is sort of a go-to study if you're trying to figure out if this is a soft tissue tumor that is solid versus maybe like a hemangioma or a cyst, So It's ideal for, particularly in the limbs, the extremities. It's a very quick way to just assess and see if is this a cyst? Is this something that looks sort of like a hemangioma, which are very common in young kids? And so it's a quick go-to. In regards to the biopsy itself, which is where we are at now, because you've imaged your patient, you've seen the MRI, you have an idea that this is a mass that you now have to sort of get some idea about. You don't know what this is, and it's sort of all academic differentials until you get a sample. Those of us that have expertise in dealing with them have very refined differential diagnosis, but it's not like we know the minute we see the MRI all the time. Sometimes like a lipoma, maybe some hematomas and a few other lesions. It's pretty academic, or you're able to sort of figure out that the differential pretty much leans towards one or two lesions. But for the most part, we have to biopsy. Biopsy has evolved over time, and now the biopsy is a little different than where it was 20, 30 years ago. 20, 30 years ago. So the principles are still the same. We talk about doing longitudinal incisions. We talk about avoiding neurovascular bundles. We try to, if you're going to do a biopsy, you ought to make sure there's not too much bleeding. The approach to the biopsy cannot be taken lightly. It is highly recommended that you talk to someone who, or at least get some advice from someone who can manage these tumors, okay, or these lesions, what to do with them. So, usually nowadays our biopsies are obtained by a needle biopsy into the tissue, and it could be done in the office, provided that you have some security about how safely you can do it in the office with a true cut needle. I'm curious to hear what if my colleagues actually do some true cut needle biopsies in the office. For example, don't have the complete setup to do this in the office, but I have musculoskeletal radiologists that are easily able to, use image guidance to direct the needle into the location we need to get the tissue that we need for the histology analysis. Probably the most important thing I could tell you is that, we don't do open biopsies as much as we used to in the past, but the principles of making sure that you achieve hemostasis and that you plan the biopsy in the area or in a way that you can resect the tumor are all still the same. The one thing that I would stress is that we consider longitudinal incisions along the long axis of the limb rather than transverse. You can see a simple outline here. Making a longitudinal incision versus a transverse incision means so much more skin is involved for the resection. It's a concept that's lost because, some of our other colleagues, our plastic surgeons, for instance, they'll tell you sometimes the lines of the skin and the creases are more transverse. And so sometimes it's more appealing to talk to a patient about a more discrete incision along the lines of the skin. But really, you ought to be thinking about, well, if I'm doing a biopsy, I must be worried about something. And God forbid and this biopsy comes back, with a malignant lesion and it needs to be resected. We ought to do more than just worry about how much we can hide the biopsy incision. It's more about, can we safely resect all of that out? I said earlier that the biopsy has to be planned. Some of our patients may be admitted to various other hospitals. They may not be with us, and you, our colleagues out there, may have, the desire to help us out, maybe get some biopsies for us before the transfer and so forth, and that's where it's pretty important to have access to us. We are available, any of us, and really, the key is, it'd be best to plan the biopsy track in case we need to go out there and, if it's malignant and we need to resect, and so again, the good thing is that most of the biopsies out there are needle, done by needle based on guidance. As you see on this image, CT, or it could be done under fluoroscopy. And, and they usually try to aim, and this is the importance of getting an MRI before, is that you want to aim for an enhancing part of the mass. If you just stick a needle in a mass, you don't know if you have, if you've got a very rich, live, viable cells, or if you've got like sort of the necrotic portion of the cell, of the tumor or the mass. If you've got some necrotic tissue that you just pulled out on a needle, chances are this biopsy may be non-diagnostic, and that's kind of painful. The patient just went through a procedure and now, probably needs to go through another procedure, or you may need to take them to the operating room and do an open biopsy. So, the key is for the radiologist to deliver some viable cells that you can make some diagnostic assessments on. Then you need some good live viable cells. And I'm not gonna dare venture into talking about histology, but the amount of and the degree of the evolution and the assessment of these tumors, as the genetic, the histologic analysis is taken on another level. They're doing DNAs and staining and all kinds of stuff. So the more we can provide, the better, the easier the diagnosis. And the needle tracts are usually excisable. This is the last image on your right here is demonstrating how you can, ellipticize along the planned route of excision and, take out that potentially contaminated area. Now, needle biopsies aren't as easy as I may have, painted them out to be. We still have some dilemmas. Getting a needle biopsy of a bone lesion can be very difficult. Here's a lesion of the proximal femur in a skeletally mature patient. My colleagues and I can sit here and probably discuss, argue, and come up with a differential diagnosis. Whether it's benign, malignant. Eventually, we may need to do a biopsy, and there's no way to get into a femur without drilling through it. And so there are risks. If it's a soft tissue, you have less of a risk. But through the bone, you have a risk of iatrogenic fracture and so forth. So, and then of course needles, unlike a wedge excisional, when you make an incision through a mass and you take out a wedge, that you can get quite a lot of tissue. But with a needle, you've got a risk of sample bias. If this is a grapefruit-sized mass and your needle just picked up a few core samples of one area, there's a potential for sample bias. You may think that this lesion is biased, but there may be a really like a de-differentiated, more malignant portion elsewhere, and so there's really nothing we can do about that except be able to, plan accordingly, have some good idea, good preoperative planning before you go in, These needle biopsies may sometimes be difficult with lymphoma. Most of us have experienced difficulty with non-diagnostic samples of needle biopsies, particularly with lymphoma of bone. So we sometimes have to go in there and deliver some tissue ourselves. So, and consider potentially prophylactically fixing a femur that we just drilled into for biopsy. So biopsy can be a little difficult with that. And this slide here is particularly to highlight what exactly is the big deal with the planned approach. If Dr. Rapp, Masrouha, and I are planning on doing a resection of a tumor and reconstructing, for instance, like the knee, it's not just about limb salvage. It's also, salvaging their function. It would be poor on my part to suggest an approach where it goes through the extensor mechanism, of the knee, for instance. That's a big deal in terms of reconstructing later. And so we choose a path. On the left, you see an image that goes through one compartment of the muscle so that you can go directly into the tissue without exposing it to any potential harm to the neurovascular bundle or to multiple compartments of the muscle. Orthopedists are, we're sort of groomed to know about intervals. Anywhere you throw us into the middle of any limb, we're like, okay, I could take that approach, the anterior approach, the lateral approach. And most of the times they are, internervous or intramuscular. And so with orthopedic oncology, we kind of stress the importance of finding something, getting the biopsy through a single compartment. So that way you have less of a contamination. Now, it's not all needle biopsies. I just told you that we still sometimes have to do excisional biopsies. And sometimes, we have such a great feeling about a lesion, a mass, whether it's a cyst or a lipoma, that we don't usually need to biopsy in advance, and we could just excise them. These are called excisional biopsies, and in this case, this was a patient of mine that had an obvious ganglion cyst near the knee that was protruding, very, palpable and visible on the knee, and just wanted to get him out. So there's still a role for this, and the key is that it ought to be less than 5 centimeters, or sort of a rule of thumb, and when it's a cyst, you could be less aggressive with the type of margins you have. But the key is really, if you're going to take out if you're going to do an excisional biopsy, and it'd be in the best interest of the patient to be to remove all of it. You want to say if the worst thing you have to tell the patient afterwards is, hey, I don't know what it is. I still don't know what it is after taking it out. The next best thing you could do is say, but at least I took it out, with with its capsule, and we all there is left to do is to assess it, and then let's hope that it's nothing malignant, and that, I think, because there are all kinds of unplanned excisions of sarcomas out there. Hey, we thought it was a benign fibroma, or we thought it was a lipoma, but turned out to be a sarcoma, and now I'm going to send it to you, my colleague who specializes in these sorts of things. And for us, one of the dilemmas will be, hey, well, did you take it out by its including its capsule, or did you leave some fragments behind? And so that's sort of the workup leading to what kind of tissue you're dealing with, and if it's benign, that's great. You pretty much can observe and manage as needed. But sometimes you come across malignant lesions, and you've got to come up with a plan. And the plan is, where else can this lesion be? Has this involved anything else in the body? And is this lesion potentially harmful? And has it, where can we identify other sites? And this has direct impact on what kind of treatment you're going to do, right? Will you have to consider systemic treatment because it's involving other sites of the body? Or can you still consider, doing a local treatment, whether it's just surgery or maybe just radiation or both? And our go-to studies in the past have generally been CT scans, and we're used to getting X-rays of the chest or CT scans of the chest. Most sarcomas metastasize to the lungs, but there are a few that metastasize through the lymphatic system also, so it could be seen in lymph nodes. Some of them tend to metastasize to spine, or even intra-abdominally in the retroperitoneum, or even in the liver sometimes. So, you'll find that our colleagues, we have a multidisciplinary discussion. Usually if I am trying to figure out whether, this is a lesion that needs to be staged, or I want to have my colleagues chime in, we have a multidisciplinary conference that we hold regularly, and we talk and we discuss whether it ought to be staged. And again, like the CT scan, the X-rays, these are things that we use. The PET scan has grown to be something more commonly used. Insurance companies still don't like paying for them, but it's become standardized with specific diagnoses. So we do use them, and once we get them and we have some idea, the question is, is this local? Is this a lesion that have systemic implications? Did we rule out any other sites of disease? Do we need to get anything? For instance, in the limb, it's not just an MRI of the lesion we get. Sometimes for instance, it's not just an MRI of the knee. Sometimes we have to get the MRI of the whole bone, and that's where the staging matters. The staging matters to determine the presence of this lesion. Is it local, or is it or is this metastatic? And it helps us guide our treatment, and it helps us talk to the patient, give them some idea about prognosis. That's one of the first things the patients ask us. Well, hey, doc, tell me what's going on here. And I can I can talk a little bit about the treatment, but the prognosis is pretty much predicated on the fact that I know whether this is metastatic or local, and I can give them some idea. And the key leaving you here is, sometimes if you have doubts, it's really important that we sort of get an idea of what we're dealing with before we talk about excisions, and needle biopsies are often the best way to go rather than an open biopsy in my eyes. And for all of you out there that might be more familiar with what we do and what kind of things we talk about, we have guidelines. It's for us, it's not sort of a random idea, much like our sports colleagues, grade rotator cuff tears about a million ways. We have ways of grading our tumors, the soft tissue staging, the bone staging. We have pioneers that have given us some idea, some insight, like, what a grade 2B is like, and what its prognosis is, and some of this is very predictable. The lower grades tend to do better and have greater or better prognosis as opposed to the higher grades. That may seem obvious, but this is all part of the treatment. And we have standard ways of discussing these even more with more detailed staging systems that we use now globally. So, Tim, that's my sort of talk on the staging, the presentation, the sort of the workup that I usually do. Anything in here that I talked about that you do differently that you want to, and Karim too, please chime in.
No, thanks. That was very, very good. Very, I think, informative. You raised the question of doing biopsies in the office. How often do I do that? Or, I think it's dependent on, your setup and what you're comfortable with. But if it's a palpable mass that's not near neurovascular structures, and, I always talk to the patient about it. I just don't go charging in there, of course. But I do them pretty frequently. I mean, I can't say one a week. It seems like you'll do 3 1 week and then not one for a month. But, I do them fairly frequently. It's quick. You don't, if there are radiologists listening, I apologize, but you don't have to go through the logistics of getting them set up for that. So it saves a lot of time and usually yields, the same result that you do by sending them to IR. Now, that said, if it's a deep mass or something that's close to critical structures, something you can't palpate, then of course, that's when I get some sort of image guidance, usually ultrasound, that at least at our institution, the radiologists handle.
So yeah, I completely agree with that.
Yeah.
I think it also is a value to the patient. It increases their satisfaction knowing that they were seen by an orthopedic oncologist who reviewed the imaging, gave them a differential diagnosis, and said, "Hey, I think you need a biopsy. I'm going to do it today, and we're going to get you a result in within a week." And I think that's especially a patient who's been told that they may have a sarcoma, they're particularly anxious about it. Helps speed things up, as Tim mentioned. You don't have to go through logistics of scheduling it.
Yeah, and for people in the audience that haven't seen one of those done, I mean, it's very well tolerated by the patient. You can do it with local. Technically, you make at least in my hands, I make a very small nick incision, but nothing bigger than you would get with an IV. It's just so I don't track skin into the biopsy track. Mm-hmm. And usually these masses are, in general, painless unless they're irritating a nerve. So in general, all these masses are in and of themselves, unless they're causing pressure on a nerve or in the compartment, the mass themselves is not painful when you penetrate it. So, watch, the next one will be, some crazy pain problem, but usually the patients tolerate it very well. And as Dr. Masrouha said, they're generally happy and grateful to get the ball rolling or, have something somewhat hopefully definitive done rather than waiting for yet more phone calls and another test to be scheduled. And you still have to wait. There's no, again, it's probably institution variable, but, I don't have pathologists in the office. So there still is the downtime waiting for the pathology, but at least you avoid the delay of getting a biopsy scheduled with radiology.
Tim, I think I went overboard a little bit with time. So before you go in, I just wanted to read a question here. Somebody said, like, I hear different implications for a fixed mass versus a movable mass. Please comment. Very quickly, usually when it's movable, they tend to be more superficial. And so it might give us sort of the impression that it might be a superficial mass, which tend to be most of the time benign, but not always. And fixed meaning more, a little deeper, maybe below the fascia, intramuscular. I mean, you can still have a mobile mass intramuscular. And so, you could have an intramuscular lipoma. It doesn't necessarily mean it's a malignant lesion, but to me, that distinction means probably superficial or deep. Do you guys read that any other way? You want to comment before you go on to your talk? Or?
No, yeah, I think, a lot of this stuff, as any, practicing physician knows, no matter whether we're talking about bone and soft tissue tumors or other things, are kind of generalizations. They're not hard and fast rules. But yeah, something that's rock hard and firm is usually of more concern than something that's soft and mobile and superficial. I mean, those are general rules. You can get fooled either way. As you showed the examples with myositis and exostosis, those are firm, fixed, hard masses and totally benign. So, it goes both ways. But in general, if you see something that's in the soft tissue that's firm and fixed, that's of a little more concern than a small, mobile, kind of compressible mass around a joint that seems like a ganglion or something else. Again, generalizations.
Mm-hmm.
All right, I don't see any further questions, so I guess we can move on to my talk if I figured this out correctly. So yeah, I'm going to talk a bit about metastatic bone disease. Again, we purposely made this webinar, kind of a broad, wanted to paint broad strokes. So I was looking at the list of attendees. I don't know by specialty, but I'm guessing, that it's a variety of people, as I mentioned in the introduction. So, this talk, there'll be little bits of it that are more surgical and parts of it that are more for everyone. So hopefully you can kind of pick and choose what's most interesting or most prudent to your practice. But metastatic bone disease, very, very common. So no matter if you're a orthopedic oncologist, a general orthopedic surgeon, or even a primary care doctor, metastatic disease in our society is extremely common. So you need, in my opinion, to know something about it. This is, I think we were talking earlier, this may come up as a pollable question. You're welcome to answer it. I'm using it more as like a teaching point, a kind of a springboard for discussion. This is something that comes up on the orthopedic resident test. It's a very old question. So hopefully even if there are residents in the audience, this is something that if you're beyond your intern year, you should know the answer to this. But it's an old question. What's the most common cause of a destructive? And the key word here is destructive bone lesion in a 60-year-old person. Really, you could change 60-year-old to 40-year-old. So anybody over the age of 40 with a destructive bone lesion, that again, destructive meaning aggressive appearing. The most likely cause of that is metastatic carcinoma, although it could be any of the other foils in this. The most likely, statistically anyway, the most common thing is metastatic carcinoma. I tell our residents here that, the one good or bad thing about orthopedic tumors is they really don't change much over time. So you can see when I first made this talk 12 years ago, what the stats are about metastatic disease. And I do look at the numbers every year. I should change the dates in the slide, but the numbers don't really change much from year to year. Cancer, very common in our society. More than 8 million Americans alive with some form of cancer. That's excluding skin cancer. So these are the visceral and lymphatic malignancies. Every year, more than 1 million new cases of primarily carcinoma diagnosed now. So we're talking about, the solid organ tumors. Behind cardiovascular disease, metastatic disease is the second most common cause of death in our society. And because it's so prevalent in society, obviously, metastatic disease to the bone is something that just comes up. Third most common site behind the lung and liver. Obviously, bone disease, not necessarily fatal, but can be very morbid to the patient. So it's important not only to orthopedists, but I think to because of the numbers, to oncologists, to even primary doctors that are following their patients that maybe have been managed quite well by medical oncologists for some time, but have bony metastatic disease. This again is kind of an old slide, but it's kind of factoids, that's interesting. Metastatic bone disease is the most common bone neoplasm if you're talking about malignancy. Dr. Wolde talked about sarcomas of the bone, which are much less common than metastatic disease as a whole anyway. The most common primary tumors that affect the bone, not surprisingly, are the most common primary tumors that are out there, namely prostate, breast, lung, and kidney. There have been multiple autopsy studies and others that show that, over 20% of cancer patients at some point in their disease process or at autopsy will have evidence of metastatic disease. And again, these are very rough numbers, but, of those 20%, a fair percentage, 10 to 15% will develop some sort of skeletal metastasis and even a fracture from that. Not always an operative fracture. And again, a lot of spine, vertebral, small, like insufficiency type fractures. So again, the numbers might seem a little inflated, and they're very, it's hard to really pin these numbers down, but it just gives you a sense. The point is that it's a very common problem, not only for orthopedic oncologists, but for anybody who's taking care of patients over the age of 40, essentially. This slide is not so important, but it's a teaching to remember numbers or anything, but it's a teaching point for the residents or anybody that just because you have metastatic bone disease doesn't necessarily mean that, everything is, that it's completely doom and gloom. Patients with metastatic breast and prostate cancer can live very long, productive lives with current medical management. Again, this isn't data, very old, but again, it hasn't changed much. And these numbers again are like all comers. So, obviously somebody that has very high grade aggressive breast or prostate cancer is going to have a worse prognosis than somebody that has kind of one of these pre-malignant lesions. So again, these are very broad numbers, but the point is that these patients can live long, productive lives. So with their skeletal metastasis, so we need to recognize that and think about that in terms of the workup and treatment of these patients. This again is just another kind of teaching slide that I show the residents every now and then. The radiographic appearance of metastatic bone disease is quite variable, as seen by that AP pelvis. So even if you're not used to looking at a lot of radiographs, you see a shot of, this happened to be a woman with metastatic breast cancer. And you see the kind of the very sclerotic lesions throughout both her femurs and throughout the pelvis, as well as some areas that are a little bit more lucent. So this is kind of a mixed pattern, which you can see. This is, typical of breast cancer, but if this was a man, you could call this prostate cancer. The point is that the radiographic appearance is quite variable. You can get lesions that are very blastic. You can get some that are very lucent. Some people call them lytic, a mixed pattern as this one. So again, anytime you see somebody with an aggressive appearing lesion of bone over the age of 40, even if they don't have a diagnosis of any sort of malignancy, metastatic disease should jump straight to the top of your differential. Why is it important? Well, obviously, orthopedic surgeons are worried about the structural support, but believe it or not, some orthopedists actually think about what else it does to the patient. Obviously, like that last patient that has significant amount of marrow involvement, metastatic disease can affect hematopoiesis, can lead to mineral metabolite abnormalities. The one that we worry most about, I'm going to talk about here in a second, is hypercalcemia. Again, even though that blastic bone that I was showing you would think it's not normal bone. If you were to look at it, and I didn't mention the histology there, that bone, even though it's reacting to a metastatic tumor. It's reacting to those glandular cells that are in the bone. So although the bone is blastic, it's not normal. It still can potentially be prone to fracture. Mineral metabolism, again, this is a classic kind of orthopedic resident training question, but it's important for anybody to think about that has these patients in their office, because hypercalcemia can be a very deadly problem for these patients with extensive bone disease. On the left is just a table showing the list of potential complaints. And again, we're talking about generally a sick patient cohort. So, these patients can come in with, feeling sick, not surprisingly, because of their ongoing cancer problems or whatever other medical problems they have. But the point is, to keep hypercalcemia in the back of your mind, because if somebody has extensive amount of bone disease, it can kind of go undiagnosed and can be fatal, because it can lead to cardiac arrhythmias, which is why it's so important, because not only do the patients feel poor, they can end up with these arrhythmias that are life-threatening. So I talked about, orthopedic surgeons. Obviously, we're worried primarily about structural support, which is true. We do think about these other things, or at least we should. The radiographic appearance of metastatic disease, as I mentioned, though, is quite variable. So this slide is just meant to show the audience this variable appearance. So these are all skeletally mature people presenting. You can read it as well as I can, with various forms of cancer. But the one slide on the upper left is what I showed earlier. This woman happened to be with metastatic breast cancer, this mixed pattern. This is a lateral of a femur in a gentleman with metastatic prostate cancer. It's very blastic. You can see the bone is kind of completely whited out, very, almost like ivory appearing. In the middle here is somebody with metastatic renal cell cancer, where there's this punched out lytic lesion in the proximal humerus. And then again, kind of a cousin to that, kind of very aggressive purely lytic lesion, is this person with metastatic lung cancer, where you have this kind of more moth-eaten permeative appearance in the bone with the, for those very astute radiologists in the audience, you can see the complete obliteration of the lesser trochanter there. So that's a very aggressive appearing tumor in the bone. So something that comes up commonly in my practice, and I'd be interested to hear of my colleagues, but I'm, and I get referrals for this particular problem, not only from orthopedists, but also from primary care physicians who, I don't expect every primary care physician in the audience to become an expert looking at x-rays, but, you get this x-ray report, which is what I would do if I was a busy primary care person, that says that you have this patient with an aggressive appearing lesion in bone, but they have no known cancer. This is a new finding. They come in with shoulder pain, knee pain, hip pain, whatever it is. You get an x-ray. What needs to happen next? Referral is fine, but what do we do? What do we think about? So that's what these next few slides are kind of getting to. As I've mentioned a few times already, metastatic bone disease, very common. The statistics say like 3 to 4% of patients present with metastatic bone disease as their presenting complaint. And that sounds like a reasonable number. I can't say I see one patient a week, but certainly one every other week. A few patients a month get sent to me for, some abnormal x-ray, destructive lesion of bone with no known history of cancer. So what do we do about it? Again, anybody over the age of 40, and I've even seen, unfortunately, people younger than that in their 30s that come in with aggressive appearing metastatic lesions of bone. So anybody with these destructive, aggressive appearing lesions, you have to be concerned about metastatic disease. And I caution you, though, although metastatic disease is very common, the most common thing that I see in my office is an incidental bone finding in an adult, is somebody that has a very small incidental finding. They have rotator cuff pathology, they have hip arthritis, they have some more garden variety orthopedic complaint. Appropriate x-rays are obtained, and they see these very small, subtle, non-aggressive abnormalities. I see a lot of that. So we're talking about here people with destructive, very different appearing bone lesions than the incidental-omas. As somebody I saw wrote it up yesterday, referred me an incidental-oma. That's, a different animal. So anybody over the age of 40 with a destructive lesion of the bone, first thing that should come to your mind is metastatic disease, metastatic disease, metastatic disease. After that would be multiple myeloma or some sort of lymphatic, basically multiple myeloma. And then third, way down the list in the third bronze medal position would be a primary tumor of bone, such as a chondrosarcoma or one of these other sarcomas that Dr. Wolde was talking about. Again, Dr. Masrouha will tell you those are more common in kids. So again, we're talking about adults, older population here. Primary sarcomas of bone are a rare finding. Not surprising, go back to med school or even, what you hear about in pre-med, what's the most important thing? We'll talk to the patient because sometimes they'll remember something that they thought was incidental or, a colonoscopy that was done 5 years ago that was never followed up on. You'd be surprised just taking a good history and even doing a good physical exam or asking about when the last prostate exam or PSA was done or breast examination or mammogram. I can't sit here and say I do prostate exams and breast exams on my patients, but nonetheless, those are questions that you can ask if you're evaluating somebody who has one of these destructive lesions with no known history. Those are reasonable questions to ask, in terms of simple things you can do to kind of pinpoint and direct further workup treatment. Laboratory analysis, I kind of poo-poo this, although I just got done talking about, hypercalcemia. I mean, we do get a slurry of labs, looking for infections, which do happen, although, again, in this age, that's more of a pediatric diagnosis generally. If you're only going to get one lab test, I suppose the test of choice would be a serum protein electrophoresis. Again, to rule out or rule in multiple myeloma, that's the test of choice. And that's, I see in my workup of these, I do find a fair number of patients with multiple myeloma. And I guess from a simple blood test that negates the need for biopsies and other painful or expensive or time-consuming tests. So if you're worried about something and you're only allowed one test, I guess my test, maybe other than the calcium, would be a serum protein electrophoresis. And then, of course, how do we work up these? So you've done a good history and physical, you get some labs. Usually these patients are already going to have an x-ray, certainly by the time they get into my office. Historically, we would get bone scans to look at the whole skeleton. But again, if you're working up somebody with an unknown primary and you're worried about metastatic bone disease, you don't find anything on history or physical, your blood work is normal. Historically, the next, I guess, 3 tests of choice that we order all at one time is a CT of the chest, abdomen, and pelvis to look for occult primary tumors, say of the lung, of the kidneys. And occasionally, those would be the 2 most common that you would find that are unknown to the patient. Occasionally, you will find some other more obscure, well, when I say obscure, or less common tumors, but really you're looking at the lungs and the kidney in these people. Chest CT, this is just somebody who had a normal chest x-ray, smoker, and then we got a chest CT that shows this mediastinal mass. Biopsy, Dr. Wolde did a great job talking about biopsy, so I'm going to kind of skip through this. We mentioned needle biopsies, which are harder to do in the office for bone masses. They're good for soft tissue masses. Usually this metastatic stuff that we're talking about is bone related. So generally speaking, bone biopsies in the office are harder to do. I can't even remember ever doing one, I don't think, just of the bone, unless it was associated with a large soft tissue mass, which generally metastatic disease does not do. That's more of a Dr. Masrouha pediatric talk. People with kids with primary malignancies of bone can present with big soft tissue masses, but generally not something you see in metastatic carcinoma. So usually, if you do need a biopsy, these are people that we do send to interventional radiology for some sort of image-guided biopsy. Again, here's another question more for teaching discussion purposes. So you see this person who has metastatic prostate cancer. At what point do you consider surgery on this? So now we're shifting a little bit more towards treatment, which obviously for orthopedic surgeons is going to be important, but also for oncologists or primary doctors, so we kind of, how we think, who's somebody that we're worried about a fracture in versus somebody that we're not as worried about. Obviously, there are medical comorbidities and many, many patient factors that go into that discussion or thought process. But in general, somebody with a large destructive lesion of bone that's generally healthy, we're going to think about surgery. So, but is there a more rational approach? And the answer is yes. And any more surgery is, I've heard this since I was in training 20 years ago, and even in my practice, I think it's becoming less and less common, although Dr. Masrouha, we were just talking before we came on the air here about, things come in waves, and we've seen in the last week a number of pathological fractures, which we hadn't seen many for a while. So it does happen, but I think with better detection, better testing, better screening, we're seeing less and less patients that need orthopedic surgery for their metastatic bone disease. That's because radiation treatment is better. It's been refined over the year. This is kind of a busy slide, but radiation for the right tumor, although it's palliative, is very powerful. Many studies that show that it has excellent pain relief in the majority of patients for quite some time. Although it may not be perfect, the majority of patients have either complete or at least partial stabilization or partial improvement in their pain. And I should mention, I guess for anybody that's still listening to me blabber on here, is that even after surgical stabilization, which we're going to talk about here in a second, for metastatic disease, the surgical stabilization stabilizes the bone, but it doesn't really do anything to treat the tumor per se. It either stabilizes the fracture or maybe prevents a fracture from occurring, but it's not treating the quote tumor. So many times, or majority of time, even after surgical stabilization, we'll still refer patients to radiation oncology. Again, many variables, but to consider adjuvant radiation to help with the patient's pain and to prevent any progression of their underlying disease. I think the biggest reason we're seeing less and less is the judicious use of bisphosphonates. Again, 20 years ago when I started out doing this, bisphosphonates were relatively new. Now they're kind of a mainstay of treatment. They're a pyrophosphate analog. They're stable against osteoclastic enzymes, obviously used quite a bit by primary physicians in management of osteoporosis, but the IV, more potent forms have been found to be very powerful in terms of preventing bone complications from cancer. It's been best studied in breast cancer, but there's been multiple articles involving multiple different tumor types regarding treatment with bisphosphonates. They help reduce bone pain, they reduce fracture risk, and have in a way minimize the need for surgeons, which is a good thing. But what are our indications for surgery? It's kind of, again, the patients are all quite heterogeneous in terms of their presentation. They have different tumors, different amounts of bone involvement. And so it can become complicated. You just don't operate on somebody just because they have metastatic disease. Obviously, we need somewhat more of a rational approach. So I believe this is an old, very simple study, although it's been replicated even recently. And I tell residents, this is a table where we score 4 different criteria that the patient presents with. And I don't think the numbers are that important. And it's a fairly straightforward, again, kind of generalization. But the things we think about, pretty simple. Where is the tumor located? How bad is the pain, which arguably is very subjective. But, there's a difference between somebody who is literally laying in bed, can barely move, versus somebody who walks into your office. The type of lesion, I've mentioned now a couple times the blastic versus the lytic appearance, and then the size of the lesion. So again, I even tell the residents not to worry so much about the numbers, but lesions that are by the hip, that are very painful, that are lytic, that are big, are at very high risk of fracture and should be, somebody to consider for prophylactic surgery. Lesions that are maybe in the upper extremity, that the pain is mild, or this was something that was picked up on a PET scan or some other scan, you're going to be less worried about and less inclined to consider surgery. So I know I'm running behind, so we'll kind of cruise through these surgical examples, but for any of the surgeons that are out there listening, what are our principles? So anytime you see somebody with a fracture or destruction near a major joint, rather than trying to reconstruct that with plates and screws or other sorts of trauma implants, generally the recommendation from a tumor surgeon would be just to resect and replace it. For more diaphyseal lesions in the midshaft of the femur or humerus, those are lesions that are, again, generally speaking, more amenable to some sort of intramedullary device. Pelvis and acetabulum, these have to be relatively healthy patients with stable disease. These are huge operations that you just don't go into. Certainly, the patient has to have functional pain and kind of exhausted all other modalities before I even recommend it. These are huge operations that really, when I say health of the patient, they have to be, a healthy patient where metastatic bone disease is really their only major medical problem. Proximal femur, I already mentioned. So for lesions in and around the hip where there's a fracture, because of the high compressive loads and high failure rates of many implants in general, we recommend resection and replacement with, off-the-shelf hip implants that the total joint people use on a daily basis versus sometimes a little bit larger implants for more extensive disease. Here's an example of, so here's a lesion, somebody with metastatic renal cell cancer in the femoral head and neck. Renal cell cancer is one of these malignancies that is not very responsive to radiations, and this is a high stress area. So although I wouldn't say it's malpractice by any means for somebody to put pins in here or screws, because of the lack of good adjuvant treatments, in my hands, I would resort to some sort of resection and either hemi or total hip arthroplasty. Again, a lot of this I've already kind of gibbered about, but here's another example, surgical example of somebody with a more permeative, kind of aggressive appearance in the proximal femur at high risk of fracturing. But there's not a lot of involvement of the neck or head. So you can imagine for doing a large resection of the proximal femur, that's a very large operation, long surgery time, long recovery time that most of these patients don't tolerate well. So this would be something more amenable to an intramedullary device, which I show here on the right, which is, people talk about hip screws. This is a long hip screw or a long nail and screws up into the hip to stabilize the bone. Again, not resecting the tumor, just trying to prevent morbidity from a fracture. Here's a more classic appearance of a diaphyseal, so midshaft lesion of the femur. This punched out lesion, affecting the cortex. So again, this would be something that's very amenable to an intramedullary device. Again, in these patients, don't generally recommend resection. There's no known benefit to the patient from resecting their metastatic bone disease for the most part. So this is something that, again, is treated to prevent a fracture, but not intended to treat the cancer per se, but to treat the morbidity from the cancer. Examples of the same, using this intramedullary device to treat that lesion. For lesions in and around the joint, again, I talked about resecting and replacing that. For smaller lesions like this lesion in the distal femur, again, that's why, there's no rigid criteria, but this one, to do a huge resection and replacement might be a little bit of overkill. I'm sure the patient was having quite a bit of pain, but this is one where you could choose plates and screws for the orthopedic surgeons out there, and then the backfill the lesion with methyl methacrylate rather than resorting to a big distal femoral implant, which are, again, long, complicated procedures with long recovery times. We already kind of mentioned the humerus being something that we can be a little less aggressive about. Here are just some examples in the humerus of a midshaft lesion in somebody with, very significant pain is something you could consider doing an intramedullary nail on versus something such as on the right where you have this pathological fracture in the proximal humerus. It'd be very hard to imagine putting plates and screws in there and getting this to heal, so that if you were considering surgery, might be something that you would consider resecting and replacing. These are just post-surgical examples of that. I guess I can't get away without talking about spine involvement, because spine involvement is very, very common in metastatic disease, although in our institution, it seems like the neurosurgeons take care of a lot of the metastatic spine disease from a surgical sense, but I look at the OR schedule frequently, and I think, there's very limited indications for surgery for metastatic disease, bone disease to the spine, basically because, again, just like spine surgery in general, these are long, potentially complicated surgeries, and maybe not the patients with the best comorbidities. So unless somebody has some sort of neurologic deficit that's progressive and failing more medical management, generally spine operations are not frequently done. This is an example of one where it was done. This happened to be an example of, this was a pediatric surgeon when I was a resident, who unfortunately had metastatic renal cell cancer and was developing cauda equina syndrome from this burst type fracture. I'm sure if there's spine surgeons in the audience, they're cringing now because this is 20-year-old slide, but shows, the point is these are huge operations to do a vertebrectomy and front and back procedure. It was a 6-hour, 8-hour operation. He tolerated it okay because he was, quote, otherwise healthy other than his metastatic renal cell cancer. But again, these are not to go into lightly. So that's it for my metastatic talk. Sorry, I've talked a little longer than I wanted. Are there any questions regarding that? I don't see any. So let's just keep on trucking here. At this point, I'll introduce Dr. Karim Masrouha, who, as I mentioned in the beginning, has done 2 fellowships in orthopedic oncology as well as pediatrics. Dr. Wolde as well, who I think will kind of assist in this part of the talk where we talk about pediatric tumors that are more interest to younger patients, pediatric patients, where we see, the majority of our primary sarcomas. So Karim, take over. I think you're on mute, Karim, still.
Okay, can you hear me?
Yeah, we can hear you now.
Thanks. All right. So in my talk, I'm going to talk about some of the special considerations in skeletally immature patients with bone tumors. And it's basically the impact of the proximity of the tumors to the physis, resecting the physis, trying to preserve it, and what are our options in these patients, how we can be creative and versatile in their treatment. So no disclosures. So I'm going to go over, tumors in different parts of the body and try to discuss some of the ways we think about these types of tumors. So for the proximal humerus, it's one of the more common sites. It's an area of substantial growth in the humerus. Most of the growth comes from the proximal humerus, and it's essential for function in patients. The challenge is that, developing a lib length discrepancy because of that growth, limited soft tissue coverage around the humerus, and poor compliance with immobilization in young patients. Also, if you resect the tumor in the proximal humerus, the stump of the canal is pretty narrow, so trying to put in an implant with a stem is very difficult, so you have to find more creative options there. And there's not much evidence because these things overall are rare. So this is an example of a study that looked at the progression change over the years and found that as of 2005, this is not a new study, but I think the numbers would show that vascularized free fibula grafting would be one of the more common ways to reconstruct the proximal humerus in children these days. And overall, the outcomes for that are okay, given the few number of patients. As you can see, the number of cases range like 12 to 25. This is a series basically of 11 patients where they demonstrated the importance of having a vascularized free fibula with vascularized epiphyseal transfer. So it's important that the epiphyseal recurrent branch of the antiotibial artery is included in that graft, and in order for it to grow. Otherwise, the physis in the proximal fibula, when you graft it, would not function. But when they found, when done appropriately, there was a mean growth in that proximal fibula of 4.6 millimeters per year. Probably not as much as the humerus was going to grow, but certainly something that will help balance things out. There were complications, obviously. There's some deformity, nerve palsies, AVN of the actual graft, and the most common was fracture, but fractures actually heal really well non-operatively. So there's a fracture of the free fibula that went on to heal, remodel, and as you can see, lengthen or grow. This is another example of how it can also thicken to even look like a humerus over time. So another option is something called clavicular prohumeral. I actually never done that before. It's only been described. It's when the proximal humerus resection is actually pretty short. You can osteotomize the medial clavicle, rotate it around, and have the shoulder joint now be the AC joint now be the shoulder joint. Obviously, it's limited by a couple of things, mostly the fact that you only have the length of the clavicle to work with, and so it's only for short resections. In addition, cosmetically, it doesn't look great, as you can see here, but functionally, these patients do okay. So what should you do? You have all this armamentarium of different options, and it's kind of tricky to decide what to do for each of these patients. And generally, it depends on your age, ability to preserve the soft tissues and function with that, and then the patient's survival. So a possible algorithm that you could use is then younger patients with metastatic disease who have lower probability of survival, putting in a cement spacer. With no mets, you can use a free fibula because that'll grow, and that's important for them. And with older patients where the endoprosthesis can be fit into the stump, then that's probably a good option. So go over some cases. So an 8-year-old female with shoulder pain, you can see there's a aggressive lesion in the proximal humerus. And this is an example of why it's important, as Dr. Wolde mentioned, to get an MRI of the whole bone. Because as you can see on the X-ray, it looked like it was probably just the proximal humerus, but you can really see the intramedullary extent with the MRI. The benefit of the MRI also is that it'll show you the soft tissue extent and any invasion into the neurovascular structures that can help plan your surgery. So this was biopsied, and that's the result of the biopsy. So I don't know if you can ask any questions, but you can have an idea what this is. And that's the chest CT. And so it's Ewing sarcoma. And with Ewing's, it's important to do a bone marrow biopsy as part of the staging as well. So it's just something to keep in mind as one of the staging steps if you have a patient with Ewing's. And so these patients actually, when they respond well to chemotherapy, the tumor can shrink on imaging. And there's recent evidence that suggests that post-chemotherapy imaging can be used for your resection. And so this patient went on to get a free fibula because they were young, and as we could see, there's no metastatic disease. However, as I mentioned, it's not without complications. The patient ended up having AVN of the proximal fibula. However, after many years, they're pretty functional. So this is an older patient, also aggressive lesion. As you can see, soft tissue extension on the MRI, no metastatic disease, and that's osteosarcoma. So because it's an older patient, no metastatic disease, went for a proximal humerus resection and reconstruction with an implant and a prosthesis. Did well, 5-year follow-up, it looks exactly the same. So this is a patient who's also 14-year-old, but very different lesion. You can see that it's not destroying the bone, it's within the epiphysis. There's a lot of edema in the area. This is very typical of a chondroblastoma. So this can be treated with curettage and grafting rather than resection. And there's a patient who has had grafting with bone substitute that eventually dissolves over time. This is a 6-year follow-up. So going down to the pelvis, this can be a very challenging area to work with, particularly in very young patients like this patient. She was a 5-year-old girl, presented with a limp, had this X-ray of the pelvis, typically done in young children who present with limps. Lots of the times, there's the causes can come from the hips. And this patient if you look closely, you can see the iliac wing looks a little bit different on one side than the other. Patient subsequently got an MRI, which shows this very aggressive lesion with a soft tissue involvement. And this is very typical of Ewing sarcoma, this sort of ballooning out of the bone without so much destruction per se, sort of more permeative ballooning out of the bone. So this patient underwent chemotherapy, and as you can see, that balloon deflated significantly. So how are you going to treat this? So Ewing sarcoma is responsive to radiation therapy as local control or resection as local control. It's a tricky one. If you're going to radiate a pelvis in a young patient, they may have develop all the subsequent problems related to radiation over the long term. But if you resect it, you're basically dooming a 5-year-old to a large pelvic resection and all the complications of that. And so this gives you an idea about the different types of pelvic resections. And so this patient gets sort of like a 1 part of a 2 in their resection. That's what this patient ended up getting. So as you can imagine, there's no more acetabulum that's supporting that proximal humerus. So over time, that's going to migrate, but eventually it stops migrating. It sort of scars in. And you can see it hasn't really changed very much between year 1 and year 2. So then like 5 years later, it's still there, but obviously there's something going on, right? And that's going to be a limb length discrepancy, which is pretty typical. The good thing is that in children, you can work with that. And what happened was that this patient got an epiphysiodesis, which was closing down their growth plates on the other side. And that was determined based on the multiple methods that we have, particularly the multiplier method that's used. And that'll tell you when you're able to stop that growth in order to even out the limbs. And over time, this patient ended up with equal limbs, even though the hips are not at the same level. Functionally doing okay now 8 years post-op. So the proximal femur, this area does not have as much growth as the distal femur, but can be problematic in some circumstances. So there's a patient with a 13-year-old with right hip pain, also epiphyseal lesion. It looks like there's a lot of swelling, also chondroblastoma. And this patient underwent curettage and grafting and did just fine. And at 5 years, maybe you can say that the femoral neck is a little bit shorter on one side than the other because when the curettage took place, that there was a growth arrest in that area, but the insignificant amount of growth that was left did not really impact the patient. However, if that was going to be done at a much earlier age and you end up with a very short neck, there are procedures that you can do, such as the mortuary osteotomy, which was made for patients with Perthes disease and coxa brava, where you can do relative femoral neck lengthening and bring the greater trochanter over. It's important to note that recent studies show that there's not much GT growth after the age of 8 in males and after the age of 7 in females. So that shouldn't really impact your decision to stop the growth over there, and they don't typically go into varus. Another modality, if you want to avoid the growth plate, is you can do a surgical hip dislocation, trapdoor into the cartilage. However, although they had decent results, they had 1 case of AVN, 1 case of osteoarthritis out of 17. It's also a lot of surgery for non-cancer And so, this is not something I've done before in the patients I've seen with chondroblastomas. That being said, most of the patients I've seen with chondroblastomas were approaching skeletal maturity. So going down to the femur shaft, this is also a challenging spot. This patient has a lytic lesion, as you can see here on the MRI, with large soft tissue component. So these patients, these are all patients, with bone sarcomas, and this patient ended up with a vascularized free fibula in their femur. But I don't know if that was the best option here. These patients, there's a mismatch in the in the width of the bone that you transferred, non-union, because you have two sites that need to heal, and it's very difficult to align. Of note, when you take a large free fibula, you need a syndesmotic screw with young patients. Otherwise, they go into valgus. So, what are the other options? And a very important option should be a rotation plasty, and this should not be considered like a last resort type thing. Patients do very well functionally with it. It does take a lot of discussion with the families. However, they function really well, and it can provide an easy way of resecting that has a reliable outcome. I don't know if this plays. You can see there's a patient status post rotation plasty with their below knee prosthesis functioning just fine. Crashing. So the indications for for surgical complications for rotation plasty, depends on where the tumor is and how much you're able to preserve from the shaft. And there are different types. The most commonly discussed is the Van Ness, which was the one I just showed in the previous case. Going down to the distal femur, this is a problematic area in young patients, particularly those with significant growth, and it's important to keep in mind either stopping the growth on the other leg, or if there's significant growth left, potentially using expandable implant. So this is a patient with a history of retinoblastoma, rhabdomyosarcoma. They had a lesion on the right side, another lesion seen on the left side. As you can see, there's tumors on both sides. And so this is a patient with a genetic mutation that results in the osteosarcoma in both lower extremities. So the patient ended up with since they're 14, they end up with a endoprosthesis, functioned okay. They had a joint sparing resection on the other side. However, these can be tricky again, because you have two areas of union that need to take place. Using a large allograft, these are highly likely to fail. If there was no tumor on the other side, you would consider epiphysiodesis in order to maintain limb length. Probably the most difficult is to deal with is the proximal fibula, the proximal tibia, because you have multiple issues here. You have the issue of limb length discrepancy. You have the issue of soft tissue coverage, and finally, you have the issue of the extensor mechanism, which you have to reconstruct. Otherwise, the patient ends up with an extensor lag. So this is a 14-year-old male proximal tibia lesion seen on the MRI. So, the surgical considerations, as I mentioned, it's the extensor mechanism, soft tissue coverage. Growth is not so much of an issue in this older patient, in 14, 15-year-olds, there are not so much, but more so patients in the age of 12 and younger. So reconstructing the extensor mechanism, as I mentioned, extremely important. You always have to do a rotational flap of the medial gastroc. But if you reconstruct the extensor mechanism pretty well, you might end up with a decent result, such as this. However, if you don't, that patella can go all the way up, and the patient will end up with a significant lag. So this is a 12-year-old, a bit younger, also with an osteosarcoma. Here, diagnosed with a core needle biopsy, as we had previously discussed. As you note, this biopsy was done through a medial approach, which is the typical, along the incision of the typical approach when resecting these tumors. So this was the musculoskeletal radiologist did this in consultation with the orthopedic oncologist who was treating. And so actually, this was a Ewing sarcoma. And as you can see from the pre-chemo and post-chemo, how these significantly change, they decrease. Unlike with osteosarcoma, these can significantly shrink with chemotherapy. And so this patient ended up with a expandable prosthesis at the age of 12. This is an expandable prosthesis that's pretty much no longer used, called the rapiphysis. The problem with it is that it resulted in significant complications, and almost none of them, actually none of them, not almost, 0% of these survive over the long term, as opposed to the Stanmore implants that are expandable. Those tend to have a bit better survival over the long term. Over here, over 2 years, this patient was lengthened. However, as I mentioned, significant problems. These patients should be counseled, and their parents, that these are temporary implants. They need to be removed as soon as lengthening is done, and replaced with a more sturdy, more permanent implant. And so that's a lot of surgery for these young patients. Failures usually of the implant, such as this, the spring mechanism completely dislocated, fractures of that as well, and failures of lengthening. And so there are 2 studies that came out recently, one last year and one this year, where I published some of the data of these patients over, I think it was 15 years. All implants failed in both studies. In the other study by Dukan, the Stanmore implants had pretty good survivorship. So avoiding problems, really, it's you either don't use the implant that's expandable, but if you have to, understand the limitations of it. Epiphysiodesis, biologic reconstruction, followed by limb lengthening, can be discussed as a potential option. You can start lengthening. You have to start lengthening early to avoid the pseudocapsule formation. You limit activity, but that's really difficult in younger children who just run around with these things in once they feel better. A very close follow-up, planning your lengthening really well, and account for limited growth during chemotherapy. For example, the actual growth in the other limb may not be that significant, so you have to measure the patients out frequently, and plan for exchange to the definitive implant when you're done with lengthening. Some studies report cases where there's epiphyseal sparing options. The epiphysis is considered somewhat of a barrier to the growth of the tumor. So these are cases where they used external fixators to expand the physis, and in order to create more of a barrier, then resect the tumor and then thereby sparing the epiphysis and then reconstructing it. And so it's sort of like a joint sparing option in these patients. Pretty good function in the long term. So in conclusion, these patients, they have have to understand their limb length discrepancies, how to spare the physis, that there are many options for biologic fixation, such in particular the vascularized free fibula has become the workhorse in younger children. Epiphyseal transfer is challenging in these patients, but it can work, as shown by the studies in this presentation. The endoprostheses are obviously sturdier in older children. They last a long time and they don't really change. The expandable prostheses are important because you want to be able to lengthen these children who are much younger, but you have to understand their limitations. Important principles in bony and soft tissue reconstruction are extremely important. And finally, the physis can be a useful barrier to preserve the joint in these younger patients. And most importantly, there's lots of things that we can do. It doesn't mean we should do them. And so understand really what your goal is, and why you're doing something, and what are the potential morbidities to the patient if you try it. Thank you.
I guess that's the end of our program. I don't see any other questions, although I'm sure there's some way for the audience to give us feedback. We'd appreciate that, and I'd like to thank Dr. Wolde, Dr. Masrouha for taking their evening to present this. Hopefully there was a little bit of something for everyone. For NYU people, obviously you can reach out to us via email. For others, if there's ever a patient that we can help with, any one of us would be happy to do that. You can find us easily via the web, just like I think everybody does now. So without further ado, I wish everybody a good evening, and thanks for your attention and interest.
Thank you.